Good afternoon, everyone. My name is Taffy Gatawa. I co-chair the Social Care FHIR subgroup, and I'm really pleased to welcome you all to our first event where we're really looking to start to share some learning around use of FHIR within social care. We've got Sophie Loseley, who is going to talk to us about some of the work that's been happening through Interweave and Yorkshire and Humber around use of social care, FHIR in social care. So I'm going to pass over to Sophie. So over to you, Sophie.
Thank you, Taffy. Thank you, May. So welcome everybody to the talk. Unfortunately, I do have a bit of a croaky throat today, so I might be sipping water a lot of the time throughout, but please bear with me. So I have been asked to speak today about how Interweave have successfully used FHIR to transport social care data within their shared care record platform. I'll first do a bit of context setting by introducing Interweave, myself and FHIR. I'll then go into a bit of the background as to why we chose FHIR for this particular project. I'll then go through some of the challenges we initially faced, followed by the approach which we used to overcome them, which is the bulk of the presentation. I will then give an overview of where we are at now and share some of the projected and realised benefits of sharing this data. I'll then end by summarising some of the lessons that we learned along the way, and I'll give an overview of where we are right now and what we are looking to achieve going forward. So I really hope you enjoyed the talk today and that some of you can benefit from our experiences and it will help you with your own projects. So just to a note about questions and discussion points. So we're going to look at questions at the end of the presentation. So if you could either place those in the chat or you'll have the opportunity to raise your hand at the end. If there is a particular slide that you are interested in, if you can just make a note of the slide number, which is at the bottom left of each slide, that would help me to navigate back to that particular slide really easily. So an introduction into Interweave. Interweave is a shared care record platform which is owned by its NHS partners. It has been developed off the back of the local health and care record exemplar project, which some of you may have heard about, which is called FHIR. Initially, Humber and North Yorkshire, West Yorkshire and South Yorkshire ICSs banded together to create a bid for the exemplar programme, which was successful. And from that project, the Yorkshire Humber Care Record was born. A couple of years down the line, it was recognised that other ICSs might also benefit from using the architecture, processes and operation models which the YHCR had created. So this was then packaged up and that became Interweave. So we operate on a partnership model and we currently have 6 ICSs using the platform. So we have the founding members, which are Humber and North Yorkshire, South Yorkshire, West Yorkshire, and we was later then joined by Leicestershire, Leicester and Rutland ICS, followed by Nottinghamshire and Nottingham in 2022. And our most recent addition was the Derbyshire ICS. The partnership model works really well for us when undertaking projects such as this. And that's because everyone has an interest in getting things to work and stakeholder engagement becomes really easy to come by through that. So a bit of an introduction into myself. So hi, I'm Sophie Loseley. I've worked in various data-driven roles within the NHS for around 14 years. Before I joined Interweave, I worked as a full-stack developer for an acute trust, where I oversaw their data provision to the YHCR. So this is when I first learned about the organisation, and their projects really excited me. So subsequently, I joined Interweave as their data service manager in 2022. I now hold the position of architect, but I still have the overall responsibility for data standards. I'm also a board member of HL7 UK and a member of the social care subgroup, which aims to promote the use of FHIR within social care. That has led me to be here today doing this presentation. If anyone is interested in joining that subgroup, we are a friendly bunch and we would welcome any new members. So please either drop myself, my contact via line if you are interested, and provide further detail. So a really high level summary of what FHIR is. And this is for those people perhaps on the call which haven't come across it before. So FHIR, spelled FHIR, is an acronym which stands for Fast Healthcare Interoperability Resources. It's a global standard which is widely used for exchanging healthcare data between systems. FHIR provides data models alongside APIs for moving those data models around. In this presentation, I will be speaking a lot about profiles and resources. So if you hear those terms, I will be referring to FHIR data models. The other thing that's great about FHIR is that it's free and really easy to use. And that is really all I'm going to say about it. But there is another really good talk which has been done by Rick Smithies, who was the HL7 UK Technical Chair, which is an introduction into FHIR, and it is available via the BCS, and I've included the link within the slide if you do want to find out a bit more. So why FHIR? A bit of a background as to why we chose FHIR for this project. Well, I guess the main reason was that we already had a platform which used FHIR, and this was successfully sharing healthcare data. We really wanted to use something that would fit within that platform. We also had a vision of having a single platform for sharing health and care data, and we didn't really want to deviate away from this if possible. And given that many of the concepts between health and care did overlap, it doesn't seem like it would be impossible to get this to work within the platform. Another reason that we chose FHIR was due to being unaware of any equivalent for transporting social care data. Further to this, our partners were really pushing for this data to be within the shared care record, and taking perhaps another route would add a lot more time and expense. So moving on to the challenges which we face. So these are some of the initial challenges. Some of them you might recognise within your own projects, but hopefully not the top one. So I've put me on there because, having worked in a health background, I had a lot of knowledge of secondary care and somewhat primary care, but I had absolutely no knowledge of, business knowledge of social care. I really only understood what the average member of the public would understand. I was also new to FHIR profiling. I had trial experience in implementing FHIR, but designing profiles was an entirely new skill set for me to master. The next challenge that we faced was FHIR, that being designed primarily around health data and not being social care focused. Another challenge that we faced was that we had several partners who have very differing landscapes and therefore differing priorities. There was also a real challenge around what people wanted to see and realistically what was achievable. Not all data at that time was captured electronically. I also realised how spoiled I'd been in the healthcare world, as there was a real lack of consistency with the social care data. Often organisations would use the same or similar terms for completely different concepts. There was also a lack of data standards to turn to. We had at the time the adult social care client-led data set, and also some work had been carried out by PRSB. But at the time, neither were very mature, but we did try to refer to these wherever possible. I'm now going to go into our approach to creating data standards. So the importance of data standards to us is paramount. Without consistent and comparable data flowing through the shared care record, we really don't add much value. Therefore, we treat data standards the same as we would any other product. We use agile methodologies and work within small development, review and release cycles. We have a dedicated team whose primary purpose is to develop, maintain and help to implement the data standards. And this consists of a data service manager, a data engineer, and more recently, an integration engineer. We also have come up with a set of principles to abide by during the development of standards, which I will highlight in the next slide. So FHIR is by nature designed to support multiple use cases, and it's very open. We therefore have to be clear that our use case for FHIR is to support the shared care record, and bear that in mind when we are developing data models. Ensuring that when we are developing profiles, we look at ways in which we can support both health and social care wherever possible. We try to build networks between related resources which add richness to the data, but on the counter to that, we try to avoid complex hierarchies, as experience has shown that for the shared care record, a simple linear view of activity is preferred. We also try to be prescriptive as possible and remove any ambiguity by saying what should be provided. Again, this is down to experience, and it's showing that people developing against profiles prefer to be told what to do rather than be given options. Capturing standard coding wherever possible. We want coded data items. Originally, this principle was about looking forward to a time when we might be able to use the data for analytics. However, we now believe that this also aids the user experience, and viewing blended data when viewing blended data, so that users can compare apples with apples. We need to focus on the fields that are important to populate and which add value, stripping out any unnecessary fields which are irrelevant to the subject matter. So that's really about creating a really clear and concise model for population. The last principle, principle 7, acts as a counterbalance to some of the previous principles. We know that we will not always get things right first time, as defining standards is a really, really complex thing to do. So we always welcome feedback. We will look to amend incorrect decisions. We endeavour to design these standards in such a way as not to introduce breaking changes. And we've not done so since I started work at Interweave, which has been fantastic. So where to start? As I mentioned, coming from a healthcare background, I had very little knowledge of social care business models or concepts. So it was really important to establish a working group who did have this knowledge and who also had a keen interest in shaping the shared care record. I approached a number of social care providers within our partnership and managed to get representatives from 6 providers on board. They had a really good mixture of systems for entering their social care data into, which was great, as it gave us a better idea of what would work. The group also contained consumers of the data and also had a good mixture of technical and non-technical representatives, most of which had a vast knowledge of social care business models and concepts. In my opinion, getting this initial buy-in from stakeholders is really crucial to success, as these are the people who will be using the shared care record and who will know the art of what is possible with their data, as well as being able to advise on what information is both useful and available to share. We also try to get other groups and suppliers involved. From memory, we had a few people attend the org meeting, but it wasn't consistent. Perhaps that was enough, but I feel that if we did have some further representation, that we might have achieved goals more quickly. We also agreed with the group that to attending weekly sessions for the period of around 2 to 3 months. And I thought that was a really important thing to do to set those expectations. So where to next? So at the first meeting, we started with a chat about use cases and decided on a handful which overlapped in each region, a bit like a Venn diagram. Once we had this, I then attempted to dive straight into the world of FHIR. And as you notice, I'll put a big red cross around that. I quickly realised that this was the wrong approach. We decided to take a step back, and we had a couple of further meetings just deciding exactly what we wanted to model in the shared care record for the first phase. Deciding on what should be shared was actually a lot harder than it sounds. As mentioned before, and from an outsider perspective, there seemed to be a lack of standardisation, not only in data terms, but in business terminology. Providers often having the same or similar terms for different concepts. But we did agree on what the things were that we wanted to model. So this then went on to us developing our first logical model to follow. We first established the real world entities, gave them mutually agreed names and a clear definition with boundaries. We then went on to determine the attributes of each of those entities. So what was it that made this thing a thing? We also looked at how the entities related to one another and established those relationships. And that led us to producing something like this. It really wasn't pretty. It was done very, very quickly, but it really gave the group some focus on what we were trying to achieve and something to refer back to whenever we felt ourselves going off track. And just to confirm that that model was indeed accurate, we then used it in conjunction with our use cases and created several documents that which looks like the one on the screen. This assured us that the relationships held true and that we had identified all the data items required. It also helped to bridge the gap between the technical and non-technical people in the meetings. So from that combination of work, we recognised that we needed to define 8 new profiles, which are on the screen. We then had the task of deciding which FHIR resources would best fit these entities. Some of the concepts, such as flag and related person, easily mapped over to FHIR resources. But given that FHIR is developed primarily for healthcare, not all of the social care concepts easily translated. So we looked at which resources would best fit in terms of logic and structure. Some of our Nottingham representatives had already undertook some work in this area, and we were able to draw on their experiences in this task. But primarily, this was a role that I undertook. And once I had just established some options for modelling each of the entities, I took these back to the group for discussion and formal agreement. So on screen are the entities, their descriptions, and the FHIR resource which we chose to model them with. I do appreciate that they are a bit small, so I'll just quickly run through what each of them say. And so contact. So the definition of a contact is a notification to social services that a person may need their support. A contact can be made by the person themselves, a relative, a health professional, or any concerned member of the public. And we chose to model that contact using the referral request FHIR resource. The assessment definition is a record of an assessment to determine a person's support needs. An assessment may be in the following statuses. So it may be in progress, has taken place, or is planned to be performed. And there was a bit of debate about how we would model this one in FHIR, but we plumped for the task resource in the end. So the flag definition, so this is active information or a warning about a person or their situation which may affect how their support is delivered. And that did fit very neatly into the existing flag resource which FHIR provides. Support reason, so the reason why the person is receiving support in the first place. And this was quite neatly modelled into the condition FHIR resource. The service is a collection of activities which deliver a support to a person which is funded by a local authority, and we chose the episode of care FHIR resource to model the service. The related person, a person who has a relationship with another person who is receiving support, for example, their spouse, relative or friend, etc. And they may optionally also play a role in the person's support, such as being a key holder or main carer, etc. And again, this mapped over quite easily to the related person FHIR resource. The next one was operational team. So the definition for this one was an organisational subunit of workers which act as a team within the organisation. And we use the organisation FHIR resource to model this. Equipment provision, the occurrence of a physical item being requested to be placed or having been placed with a person to aid their support. And we chose the device request to model the equipment provision. So you may have noticed that the patient practitioner role and organisation resources which have relationships with these entities in the previous diagrams are not included in this list. This is because we had already profiled these resources during the healthcare work. And a quick review of these showed that no changes were required to enable their usage. So after the FHIR profiles had been agreed, we then needed to get down into the nitty-gritty and look at how we map the individual attributes from each of the logical models into the FHIR fields. To aid this work, we created this working document, which is on the screen. This was used during the group sessions and populated. You can see at the very top of the screenshot that we have the description of what is being modelled and the FHIR resource which is being used. I then listed all the FHIR fields available for that resource, along with their base conformance and cardinality. It was important for us to remain FHIR compliant, otherwise the structures would not work within our current platform capabilities. Therefore, we needed to understand what could be changed in terms of conformance and cardinality and what could not. For example, FHIR have a number of mandatory fields in their base standard, and even if they are irrelevant, we still need to keep those within the profile to remain compliant. We then went through the list of fields and mapped the social care attributes to the most suitable candidate. We discussed the right description for those fields and also their conformance and cardinality. For the fields which were coded values, we looked first to the adult social care client level dataset and then to SNOMED. Sometimes neither of those had suitable coding systems, which meant we had to generate our own. We did unsuccessfully try to get some of our own codes into SNOMED, but we never really found that route in. You will notice in the example that a lot of the irrelevant health fields have been completely stripped out, and that was really to create a really clear and concise model for population. The file was then circulated after each meeting, and this allowed members to reflect upon the discussions that we'd had and note down any queries for follow-up at the next meeting. So once we had been through this process with each of the entities, I then proceeded to translate the document into FHIR profiles. So once I had done that, the profiles were merged into our existing FHIR implementation guide and published in draft status. These were then circulated to all our partners for review and comment for a 2-week period. After that review period, the new profiles were presented to our technical design authority to be officially approved. And once they were approved, the profile statuses were updated for trial use. We also set up monthly check-ins to monitor progress, check for any issues being experienced, and to give a platform for organisations to share their experiences. And this took place for around about 6 months and seemed to really help support people with their implementations. So this is an example of our FHIR implementation guide, and in particular a view of a FHIR profile. It's quite hard to fit it onto one screen, so I've kind of split it onto 3 separate slides. But at the top of the FHIR profile, we have nice details such as what the actual definition of the profile is. There are some examples. We find that developers really like to see examples of how the data is modeled, so we always try to provide those wherever possible. If we were to scroll further down on that page, we would start to see some narrative around some of the fields. So we try to list at the top of the page in a real nice, neat and succinct way which fields are mandatory, which fields are must support, and which fields are optional. And we also, in a human readable way, describe what that field should contain, and also talk about any design decisions made and why they were made. Then later down the screen, you get the actual technical representation of the profile. These profiles are totally free to be used by anybody else. Please feel free to extend upon those for your own projects. If there is anybody who's technical on the call, and just for information, we happen to use Fish, Sushi and the free IG publisher to create our implementation guides. We have looked at other projects to produce the implementation guide, but I think we like that more granular control. But yeah, it's each to their own really on that one. There's also a link on each of these slides, just giving you the pointer to where you can find the implementation guide online. So progress so far. So this is a data provision matrix of our local authorities which are providing into the shared care record. I've tried to keep it as simple as possible, as there is a lot of data on there already. So the green squares on there are what is currently live, and the blue squares are what are currently in development. But what it doesn't really show is that a lot of those blue squares are very close to going live. A lot of those are in the staging environments or in clinical safety sign-off processes. So maybe in a couple of months' time, we'd have a lot more green on this grid. And again, there's just a link at the bottom of the slide there to our full data provision matrix, which is freely available via our website. So next, on to partner benefits. So Humber and North Yorkshire are still undertaking their benefits work, but one really key piece of information that they wanted to share was that they're already seeing a huge benefit from just providing the practitioner details. This is reducing the amount of calls which are having to be triaged by North Yorkshire Council, and it's freeing up their staff to be able to perform other services, which is fantastic. Leicester, Leicestershire and Rutland provided me with a fantastic piece of work that they have undertaken, and it is probably worthy of its own presentation. So I've really cherry-picked the pieces of information that really stood out to me. So they have currently identified 24 use cases, 21 of which are being fulfilled already by the service data which is being provided. And the remaining use cases are going to be realised by sharing the remainder of the social care data, which we have already profiled. They have said that the benefits that are being anticipated or realised are very often linked to time saving, plus one or more other things such as better care, improved patient experience, and less duplication of resources, etc. I've also got some nice quotes from LLR. So this first one in the top corner is really about a GP being making it really easy for them to find out which council they need to speak to should they need to get in touch about somebody's social care, and also improving their own work experience and to reduce the stress that they're under. The quote on the far right is from somebody who's a practitioner in the urgent assessment and therapy. So they talk about how it reduces admissions. So if they can see that they've got a care package in place at home and it's appropriate to do so, then they can discharge them to home, knowing that they will be in safe hands. And another quote that we've got on the screen there in the middle is from a community nurse. And she stated that just being able to see the social care, who is the social care provider, saves her an hour and a half chasing around and trying to find that information. So I think those are really, really powerful quotes. So I'm now just going to review some of the lessons that we have learned along the way. So I think the first lesson for me was about spending more time defining use cases and benefits. Although we did identify a handful of use cases during this project, I think it would have been better to have a wider stakeholder engagement and again to work that through into what benefits could be realised. Second on the list there, we've got defining the logical models first. I think that was really, really an important thing to do, especially because FHIR is a healthcare focused. You need to understand what it is that you want to model first. Also have some really clear and realistic objectives for the working group. I hate using this term, but don't try to boil the ocean. Make sure it is a small set of data that you are trying to model out first, and you can do that well. And it's also another lesson is about bridging the gap between, logical and technical. So everybody who's involved within that working group is engaged and contributing. Another lesson which I perhaps would say is to try harder to get more groups and other suppliers involved in the designing of profiles. I'm not quite sure how to achieve that other than just going around and begging people to come along to our meetings. But I think that they could really give some better insight into what we should be doing. And lastly, don't be held back by perfection. It's really hard, but I think you've got to come to a point when you realise that we're going to provide a benefit here by getting that data out there and shared. So if you're going to be 80, 90% there with something, just please start rolling it out. So what's coming in the future? So this is really short-term future for us. We're looking for the ICSs to mature their local authority data provisions. And that is by getting them to provide the extra data items which they are not currently, and also onboard any other local authorities which are yet to onboard. Another target for us is to get social care providers, children's data providers and community and domiciliary care on board as well. So the next one really overlaps between health and care. But we're hoping to consume the reasonable adjustment flag, the CPIS and FGM flags, which will be available via the NHS FHIR API. A really large piece of work that we're currently undertaking is to uplift us to R4/UK core. We currently work on Stu3 and Care Connect as our base profiles. So that is going to take a bit of time to do, as it's all about the infrastructure as well as modelling the profiles. Another piece of work that we're currently undertaking is creating some personas. So we really want to do this to make sure that we have accurately captured what people need to see from the shared care record. And again, that one kind of crosses between health and care. We're also hoping to do some gap analysis between MODS and the PRSB standards. So if there's anything that we can do to improve our current profiles. And finally, we'd like to get these profiles PRSB assured. So that brings me to the end of the talk. I would just like to say that this was definitely a group effort. It wasn't just myself. So thank you to all of our partners for their help. And thank you to those partners who give me the information on the benefits too. And lastly, thank you to the audience for listening to me. I will hand back to Mike, who will help hopefully organise the questions that we might have. Thank you.
Thank you very much, Sophie. That was excellent. And your voice sounded a bit Dalek-like in the middle, but seems to be a bit better now. So many thanks indeed. So I think Taffy and I are going to run through the questions that have come up in the chat and see if you'd like to answer them or if anybody else in the audience can contribute. So Taffy, do you want to run through those or would you like me to?
Yes, happy to, Mike. Thank you. First question then. Interweave delivers 3 shared care records covering 5 regions. That's a question from John George. Are there plans to expand Interweave's shared care record to other regions? And what about rolling this out nationally? Can NHS England help? So part of that question seems to be a question to you, Sophie, and perhaps a question to any NHS England colleagues that might be on the call.
Yes, I suppose what I can say from the Interweave standpoint is that we're not aggressive in our approach. It tends to be people, ICSs, come to us to have a look at our platform, and if they're interested, then we'll open up, talks about becoming a partner. Yeah, again, the second half is really down to NHS England, I guess, to answer.
Any takers from NHS England?
I suspect, sorry, just let me say something quickly. I suspect this is a big picture thing that needs to be taken offline, but if anybody from NHS England does want to quickly come in, that'd be great. But I mean, I think this is one of the reasons that we have the FHIR board and why we're all working together to see that we can get good work that's been done around the country spread more widely. But did I hear somebody from NHS England wanting to come in?
I can't see any hands up. So yes, so maybe we take that one offline.
Yeah, but I mean, it is the fundamental question almost, isn't it? I mean, how do we spread these things around? I can see Martin,
you've got your hand up.
is raising his hand.
Sorry,
literally.
not familiar with Zoom, and I couldn't find the raise my hand button somewhere. So sorry, work that one out. I can't speak for NHS England, but all we know about at PRSB about all the different shared care records is that essentially it's the responsibility of ICSs, and many of them are approaching it in different ways, and they have suppliers that are doing it quite differently, and to many of them have more data warehouses and so on that they're building, as opposed to the Interweave approach. So it's certainly independent. Whether that's right or not, I'm not commenting, but hopefully that's helpful.
Thank you, Martin. Eleanor asked the question, were the SNOMED CT codes for social care that have been developed by Catalonia considered?
No, I wasn't aware of them, unfortunately. So, no, unfortunately, there wasn't at the time. But it would be really nice to have a look at those now I am aware of them and see if we can use them within the profiles.
Okay, thank you, Sophie. And then George asks, what were the barriers for Interweave to use the UK core FHIR profiles, assuming those were appropriate for UK FHIR profiles available?
So this piece of work actually took place a couple of years ago. And our base was at the time and still is Care Connect. So we do base it on the Care Connect profiles, which was a predecessor to UK Core. And because our platform worked with STU-free, that was kind of really the barrier for us. But we are moving forward and we are going to be looking to convert to R4, but it is quite a huge piece of work.
Thanks, Sophie. Richard asks, the creation of the minimum viable data set is great work. Is this a product of Interweave now, or is it en route to becoming a more national governed asset?
So currently it is just Interweave who owns this, I guess. And like I say, it is free for anybody to use. If it could be adopted as a national asset, I'm sure we would be happy with that. But I'm not quite sure which road you would go down to get that done.
Yeah. And then another question from Ian: which vendor solutions are operating within the Interweave Yorkshire and Humber patch? And what's the level of support for native FHIR over mapped FHIR? And have the vendors been receptive to the profiles?
Yes, so the vendors that I can think of just off the top of my head, we've had Liquid Logic and Mosaic. We do leave the actual mapping down to the organisations themselves, so we've not actually been involved with the conversations directly with the vendors. But perhaps that's what I was trying to say earlier. We would like to get those suppliers in the room for any future developments and get their input. I think that'd be really, really valuable.
Yeah. John, I can see you've got your hand up. Did you want to come in at this point?
Yeah, just one of my questions wasn't answered. Has Interweave been invited to attend the clinical and technical assurance meetings to drive the design of the UK core FHIR profiles?
I don't believe so.
Okay, all right.
Sorry, can I just check? Is that the TIG?
No, this is the clinical and technical assurance. No.
No, then.
Okay.
So if you would like to send me an invite, that would be fantastic.
Yeah, I think we'll get that arranged.
Okay, and there's a question from Callum asking if Simplifier was considered, and if not, why not?
Yes, we did consider Simplifier. Myself and the current data service manager both had a bit of a trial with it, but we found it a lot harder to use than actually doing the fish ourselves. And I don't know if that's because we're both from a developer background and we like to really get down into the weeds of things. I think it's horses for courses. Some people will prefer Simplifier, some people would prefer doing a bit of hand coding like what we do, but we just prefer that bit more for granular control over things.
Okay, so slides, I think we talked about slides earlier, so these will be posted on the BCS website, so they'll become available. And then there's a question from Martin: are medicines out of scope for patient resources or a lack of FHIR data on products?
Medicines, was that, sorry?
Yes, medicines.
So for this particular project, we didn't consider medicines, but we have considered medicines on the health side previously. So we do have FHIR profiles for medications there.
Okay, thank you, Sophie. I think I've picked up most of the questions. If there are any other questions that either haven't made it into the chat, people, please feel free to just raise your hand and then we'll take that question. We do have a bit of time left.
While people are thinking, I don't know if any of my colleagues from HL7 UK would like to say anything about Simplifier versus fish and sushi. It's a bit of a technical subject that might be better for the technical implementation group or another venue, but if you want to weigh in here, that would be great. Doesn't look like it. And it also doesn't look like it also doesn't. I've just seen a message from one of my colleagues saying he's at the airport, so I can see why he doesn't want to answer. Okay, so that's interrupted my train of thought slightly, but yeah, it doesn't look like we've got any more questions. So I suspect the best thing to do is to wrap it up at this point, don't you think, Taffy?
Yes, no, totally agree.
Okay.
Thank you very much, Sophie. I mean, I think that's been very, very informative. And we will share the slides, as we've said, but really good session. And thank you to all the participants who've made the time to come and share this. We're really keen to start to share more of the work that we're doing within the social care space around FHIR. So thank you again for making the time. And thank you, Sophie, for a wonderful presentation.
Yeah. So, okay, well, thank you very much indeed from me as well, Sophie. Excellent presentation, as Taffy has just said. If Taffy and Sophie would just like to hang on so we can have a quick debrief, but otherwise, thanks again to everybody for your participation. We'll be announcing the next one because we're planning to have several of these sessions about FHIR and social care as soon as we can. But in the meantime, have a good afternoon and thank you again for attending.
Thank you, everyone.